Next up we've got Judy Holland, who's the head physiotherapist at Calvary Mater, Newcastle, and Judy's going to present looking outside the square for early lymphedema management. Thanks, Judy.
No, that's going backwards, that's going forward. Okay, as with most changes in models of care, I guess our change in model of care came from a problem. Just to give you a little bit of perspective on our problem, I need to tell you a little bit about how big the Hunter New England Health Service is. So the Hunter New England Health Service covers an area that's the same size as England. It's about 1.5 times the size of Tasmania. It's 130,000 square kilometres. Takes about 5 to 6 hours to drive from one end of it to the other. And we have about 850,000 residents living in that area. So that's the size that we're covering. To tell you a little bit about our Lymphoedema Services back when this problem first came to the forefront, I guess, there were two main services situated in the Greater Newcastle sector that managed lymphedema. There was a smattering small services out in the rural sector that also managed lymphedema, with one of the main ones being in Tamworth and another one at Muswellbrook. Okay, so they were sort of situated, and I'll show you on a map here about where they were situated. So the yellow stars, unfortunately, were the services that probably brought about the biggest issue for us. They disappeared. Okay, so the green services still existed back in 2010 when the issue arose. One service up in Armidale, which was a physio who sort of did a rotating position, so she supplied services every now and then depending on where her rotation happened to be. And then the two services, mainly Tamworth and at Muswellbrook, one of the physios retired due to unexpected family situation, and another physio moved into an educational role and was unable to provide any clinical services anymore. The position up at Moree again was a very rotational position, and that physio has subsequently left that role as well and moved back to Newcastle. So in 2010, I guess my hair went very great. Head of the physio service, we're a big cancer service, and we provide the major radiotherapy services at the time, and so therefore most of the referrals were coming to us, and then we were referring back to the rural sector for them to then manage the situation when the patients went home after having their radiotherapy. So in 2010, when the issues of people disappearing from the rural sector occurred, we then had nowhere to refer these patients back to, and we were getting more and more patients coming down to us from the rural sector with very significant lymphedema situation that had received absolutely no services in the time up until they attended radiotherapy services. So for most of those patients, that's from when they were diagnosed through to when they start radiotherapy is a good 3 to 4 months of having lymphedema problems by the time they got to us. So I guess as the patient population became more aware of the situation, people are recognising what lymphedema is, they understand it a little bit more, they demand more services. The story we were getting down where we were is, why can't we have any services in our local area? What's going on? What can we do? And we were getting more and more push from the patients about what can they do back home. The reduction, obviously, in the rural services was a major issue for us. Obviously, we had nowhere to refer these patients back to. They were Tamworth's about 3 to 4 hours away from us. I have patients coming from Moree, which is probably about 4 to 5 hours away, depending on what your travel speed is. So these are big distances for these patients to be travelling. We do not have a doctor attached to our service, so they don't get IPTAS payments for that, and therefore this is a very big out-of-pocket service for them to come and access. In the rural service, and with a lot of clinicians, and I don't think we stand alone in the Hunter New England, treating lymphedema patients is a fear. It's something we're not taught at uni, it's something that you take on as a postgraduate education, and therefore people were just not willing to actually start seeing these patients and treating them. And I think sometimes it was felt that they were going to be a very cumbersome situation to deal with in their practices. And as a lot of sole practitioners can't afford to have patients that are going to be on their books for a very long time. And that's what these patients were seen as. And I think that was a picture of very antiquated knowledge on what lymphedema is and how to treat it, and also the things that can be done in a very timely fashion if it's done early enough for these patients. We then had the listening posts that the Cancer Network ran in Hunter, New England in 2011, and again there was more feedback from patients at these listening posts about the lack of lymphedema services, and I guess as a relief to myself, the Cancer Network executive came on board in helping to support actually developing something to move forward with this problem. We also had the picture of a change of our radiotherapy services. They were opening up a service in Tamworth, which would mean that the patients that used to come to us from Tamworth would now have their radiotherapy in Tamworth and would have actually no access to lymphedema services because they were no longer coming to Newcastle and actually touching base with us at that point when they came to radiotherapy. Unfortunately, the radiotherapy service up in Tamworth did not get any funding to be able to support a physio to supply any lymphedema services in that area. But they're trying. Okay, so with the support of the Cancer Network service in Newcastle, we had a look at the problem and came up with a few solutions that we thought might tackle a few of the issues. It's definitely not an absolute solution, but it gave us something to start with. So we needed some good resources to be able to help patients have self-management techniques so that they could actually start instigating some self-management while they were waiting to get to see services, and that may be all they needed to do. With cancer patients, sometimes they just need some basic skills to start off with. We wanted to improve early education and, again, that self-management understanding for patients, and also give them the advocacy to be able to say, I actually think I'm developing lymphedema, to be able to recognise the signs and symptoms of when things are starting to go wrong for them. And we also wanted to develop some education for all staff so that everybody was on the same page and was able to start patients on a self-management program before they could access any other more specialised services if that was what they needed. Because sometimes, as I said, all they need is some basic self-management skills. So how we decided to go about this is we luckily got given a $20,000 grant from the Cancer Network in Hunter, New England, to develop a DVD. And this was put into the foray in 2012 with one of my physios. She developed the basic package. The filming was done at the service. It involved two of our patients. And I think that was a really nice touch. Our production crew were really, really good. We had a really nice story from each of the patients, and they demonstrated the techniques. They talked about how that fitted into their life and how they'd managed to incorporate what they'd learnt and how they'd incorporated basic management skills into their life. So one of them was obviously a breast cancer patient who'd had an axilla dissection, and one was a melanoma patient who'd had a groin dissection. So we covered arm and leg. Obviously there are other areas that do develop lymphedema, but they probably needed more specialised treatment anyway to be able to deal with that. So this is a picture of our DVD. Peter was a melanoma patient, and he was a very, very strong advocate for melanoma, and he was an absolute champion. And Carol was a breast cancer patient who was willing to also participate. It was a bit hard to round somebody up to do it, but two really good stories came out of it, and we've had really, really good feedback about the DVD from patients. The other thing that we did was look at using the education group that we were already running at the Mater. So when we hit rock bottom, I think in 2010, and we were just getting this massive influx of referrals, we decided to try and stream some of our early patients and the patients that just need a little bit of education, a little bit of self-care taught into a group situation rather than doing individual situation with them. So we were already doing that, and thanks to, again, the Cancer Network, they got on board, and we got a Cancer Institute grant to actually get some telehealth services into the room that we were doing the program through, so that we could then telehealth that out to some of our rural sites. So we were targeting Tamworth, Muswellbrook and Taree as our primary sites to do our connections with. So that took a lot longer than was expected, but we have finally got that in and got up and running. Unfortunately, we've only done 3 conjoint telehealth sessions, so I don't have a lot of feedback yet, but it is up and running. We're slowly getting into the roles of rolling that out. This is our telehealth room, and I probably should have titled my talk today about looking inside the box instead of outside the box, because it really is a lot of looking inside the box. We've got DVDs and TVs, but you know, this is, I guess, something that we need to embrace. Telehealth is a way to move forward, and it's a very difficult area for physios, I think, to move into, because it's such a hands-on situation normally. And I am grappling with it a little bit, but we're getting there. So I think the more sessions I do, the better I'm going to get at it. From the staff education point of view, we've invited staff to attend the telehealth sessions. So that the nurses at each site, the cancer coordinator nurses that are helping set it, have sat in on the sessions. So that's a start. We've also just joined up with the HETI organisation, and I'm on the steering committee to actually start building a Moodle, an online project to enhance general education of lymphedema, so that can be rolled out across New South Wales, and I'm very excited about that, because I think it's something that could actually move this condition forward a long way. And I'm doing a lot of presentations at as many forums as I can, you know, breast care nurses forums, allied health forums, to try and push out the knowledge and get the knowledge up to where it should be. Some of it is very antiquated, and I think everybody can take a role in giving patients self-care information. So the feedback so far, as I said, we've only done 3 rural connected sites so far, sessions so far. I have had some very positive feedback from the participants, and hopefully over the time I'll get more of that together and be able to actually present some of the feedback. I don't think I've done enough of them yet to get a good feel of it. The first session, I guess, was probably the groundbreaking one. Getting out exactly the patients that this needs to target was not probably done best by my situation, but hopefully as we subsequently roll on, because the people that came to the first one were already established lymphedema patients, and they probably weren't a great target population, but hopefully we'll move forward with that. The lessons I've learned, cross-discipline and across large geographical areas is very hard. If it hadn't have been for the Cancer Network executive, I probably would never have got this off the ground. Obviously, I'm a physio, I'm dealing with a lot of nurses, and they're in geographical areas that I have nothing to do with, so the connections are not there, and without the guys who do have those connections, I don't think we would have got off the ground, and there's been a lot of work done just to get those people targeted at the other sites to help run this. The other big issue, I think, for me was I carry a clinical load. I'm also an administrative manager, and trying to run a project in the mix of doing all of that did cause a lot of problems, because things would get on the back burner because of other situations that came up. So I think really this would have been better done as a project with a project manager as a driver, but we didn't have the funding for that at the time, but that's something that I would think about in the future. And as I said, the clear definition of my target population probably didn't get across very well at the beginning, but hopefully that will get better as we move on. I'd like to acknowledge the Cancer Network for Hunter New England. They've been a great support to me. The Cancer Institute obviously helped also with the grant, and we would not have got this rolling had we not got the grant money. And obviously the physios at the Mater have been a great support to me and helped me through this, because it has been quite an arduous task. That's it.